Hello friends, in this video we'll be talking about one of the most important complication of the third stage of labor, that is postpartum hemorrhage, and it is one of the frequently asked question in MBBS final year. And so we'll be mostly discussing about its introduction, its causes, its diagnosis, clinical feature, its management, and finally the most important part, that is management. And we'll be talking about everything about this in detail that is necessary for MBBS final year examination. So, what is postpartum hemorrhage? The quantitative definition is arbitrary, and it is related to the amount of blood loss in excess of 500 ml following the birth of baby, that is given by WHO. More than 500 ml after the birth of baby, that is arbitrary definition, and that is useful for statistical purpose. But what we have is that as the effect of the blood loss is important rather than amount of blood loss, the clinical definition is more practical. States that any amount of bleeding from or into the genital tract following the birth of baby up to the end of the puerperium, which adversely affect the general condition of the patient, evidenced by rise in pulse rate and falling blood pressure, is called postpartum hemorrhage. And visual estimation of blood loss is inaccurate, and therefore the clinical sign and symptoms should be included in the assessment of postpartum hemorrhage. And according to ACOG 2017, the postpartum hemorrhage is defined as excessive bleeding following delivery, that is more than 500 ml in vaginal delivery or more than 1000 ml in cesarean delivery, accompanied by sign and symptom of hypovolemia, and this is known as postpartum hemorrhage. More than 500 ml in EC vaginal, more than 1000 in cesarean, with sign and symptom of hypovolemia. This point is important, with sign and symptom. And the average blood loss following the vaginal delivery and cesarean delivery and cesarean hysterectomy is like in vaginal delivery it is 500 ml, in cesarean 100 ml, and in cesarean hysterectomy it is 1500. And depending upon the amount of blood loss, PPH can be of minor type, that is blood loss is less than 1 liter, major where the blood loss is more than 1 liter, and in severe the blood loss is more than 2 liter. And sorry, there is one mistake, that is it is more than 1 liter. And the incidence of the postpartum hemorrhage varies widely, mainly because of lack of uniformity in the criteria used in the definition. And the incidence is usually 4 to 6% of all delivery. And the types of postpartum hemorrhages: one is primary, that is early PPS, and secondary or late PPS. And in the primary or early PPS is defined as the hemorrhage occurring within 24 hours following the birth of the baby, and in majority the hemorrhage occurs within 2 hours following delivery. And these are of two types. Third one is third stage hemorrhage, that is bleeding occurs before expulsion of placenta. One is third stage hemorrhage, that is bleeding occurs before expulsion of placenta, and in the true postpartum hemorrhage the bleeding occurs subsequent to the expulsion of placenta, and this is true postpartum hemorrhage occurs in majority of the cases. And secondary PPH is defined as where hemorrhage occurs after 24 hours and within the puerperium, and it is also known as delayed or late puerperal hemorrhage. Now we will be talking about primary postpartum hemorrhage in detail. Now, what are the causes of the four basic pathologies are expressed as 4 T's, that is tone, tissue, trauma, and thrombin. These are the mnemonic, and these are related like tone, atonic type. The four causes of postpartum hemorrhage are atonic, tissue, that's a retained beat or blood clot, retained tissue, trauma, one is genital tract injury, and thrombin, that is coagulopathy. Due to this reason, the primary postpartum hemorrhage occurs. Talking about one of the most important cause, that is atonic uterus. It is found in 80% of the cases, and atonicity of the uterus is the commonest cause of postpartum hemorrhage. With the separation of the placenta, the uterine sinus, which are torn, cannot be compressed effectively due to the imperfect contraction and retraction of the uterine musculature, and the bleeding occurs. Here in the uterus, the blood vessels are running through the interlacing muscle fiber, and they are literally clamped due to the effective retraction of the uterine muscle. And in atonic uterus, this is prevented, and that causes bleeding. This blood vessel cannot be clamped up, and that result in bleeding. And these all conditions usually interfere with the retraction of the uterus as a whole and of the placental site in particular. One is the first cause. We have the grand multipara, that is causes atonic uterus. Why in the grand multipara? Due to inadequate retraction and frequent adherent placenta contribute to it. The associated anemia may be the probable factor. And the over distension of uterus, as in the multiple pregnancy oligohydramnios and the multiple pregnancy polyhydramnios and the big baby more than 4 kg, the imperfect retraction and the large placental site are responsible for excessive bleeding. And the malnutrition and anemia less than 9 gram per deciliter hemoglobin, and even the slight amount of bleeding blood loss may develop clinical manifestation of postpartum hemorrhage in this condition. And antepartum hemorrhage, both placenta and abruptio placenta, these the causes of excessive bleeding there occurs. And the prolonged labor, prolonged labor of more than 12 hours due to poor retraction, infection, amnionitis, dehydration are important factors for the degree stone. And anesthesia, depth of anesthesia and anesthetic agent like ether halothane may cause atonicity. Inhalation or augmentation of the delivery by oxytocin, post-delivery uterine atonicity is likely unless the oxytocin is continued for at least 1 hour following delivery. Next is uterine fibroid causes imperfect retraction mechanically and mismanaged third stage of labor. This includes too rapid delivery of the baby, preventing the uterine wall to contract so rapidly, the premature attempt to deliver the placenta before it is separated, and the kneading and fiddling of the uterus, pulling the cord. All these produce irregular uterine contraction leading to partial separation of placenta and hemorrhage. And the manual separation of the placenta increases blood loss during cesarean delivery. And the placenta moderately adherent accreta, percreta, partially or completely separated and or retained due to reconstruction ring of the uterus cause postpartum hemorrhage. And the precipitated labor in rapid delivery, the separation of the placenta occurs following the birth of baby. The bleeding continues before the onset of uterine retraction. The bleeding may be due to general tract trauma also. And the factor like obesity, BMI more than 35, previous history of PPS, age more than 40 years, and drug use of tocquiolytic drug like ritodrine, magnesium sulfate, nifedipine, these all can also cause postpartum hemorrhage. And we have the traumatic PPS. The trauma to the genital tract usually occurs following the operative delivery. Even after the spontaneous delivery, the blood loss from the episiotomy wound is often underestimated. Similarly, blood loss in the cesarean dissection amount to 800 to 1000 ml is most often ignored, and trauma involves usually the cervix, vagina, perineum, the episiotomy wound and the laceration, paraurethral region, and rarely the rupture of uterus occurs. And bleeding is usually revealed but can rarely be concealed, but that is in vulvovaginal or broad ligament hematoma. And the retained tissue like beads of placenta, blood clot can cause PPS due to imperfect uterine contraction, and ultrasonography and echogenic mass is suggestive of retained tissue. Thrombin, the blood coagulation disorder, acquired or congenital, are less common causes of postpartum hemorrhage. The blood coagulopathy may be due to diminished procoagulant washout phenomenon or increased fibrinolytic activity. The firmly retracted uterus can usually prevent bleeding, and the condition where the such disorder may occur are abruptio placenta, jaundice in pregnancy, thrombocytopenic purpura, severe preeclampsia, HELLP syndrome, amniotic fluid embolism, or in intrauterine death. And specific therapy following coagulation screen including recombinant activated factor 7 like may be given, and the combination of atonic and traumatic causes are may be there. Talking about diagnosis and clinical effect, in majority the vaginal bleeding is visible outside as a slow trickle. Rarely the bleeding is usually concealed as either vulvovaginal or broad ligament hematoma, and the effect of blood loss depends on the pre-delivery hemoglobin level, the degree of pregnancy-induced hypovolemia, speed at which blood loss occurs, alteration of blood pressure and pulse pressure appears only after class 2 hemorrhage. On occasion, blood loss is also so rapid and brisk that the death may occur within the few minutes. The state of uterus as felt for abdomen gives a reliable clue as regards the cause of bleeding. In traumatic hemorrhage, the uterus is found well contracted. In atonic hemorrhage, the uterus is found flabby and becomes hard on massaging. However, both atonic and traumatic causes may coexist, and even following massive blood loss from the injured area, a state of low general condition can make the uterus atonic. Prognosis of postpartum hemorrhage is one of the life-threatening emergencies. It is one of the major causes of direct maternal death both in the developing and developed country. And the prevalence of malnutrition and anemia, inadequate antenatal and intranatal care, and the lack of blood transfusion facilities, substandard care are some of the important contributing factors. And there is also increasing morbidity, and these include shock, transfusion reaction, puerperal sepsis, failing lactation, pulmonary embolism, thrombosis, and thrombophlebitis. And the late sequelae include the CN syndrome, that is selective hypopituitarism, or rarely the diabetes insipidus can occur. Prevention. The postpartum hemorrhage cannot always be prevented. However, the incidence and especially in its magnitude can be reduced substantially by accessing the risk factor and following the guidelines as mentioned below, as we will talk now. And however, the most of cases of PPS have no identifiable risk factor. And in antenatal period, the improvement of the general health of the woman and to keep the hemoglobin level normal more than 10 gram per deciliter so that the patient can withstand some amount of blood loss. High risk patients who are likely to develop postpartum hemorrhage such as twins, hydramnios, and grand multipara, APS, history of previous PPS, severe anemia are to be screened and delivered in a well-equipped hospital. The blood grouping should be done for all women so that no time is wasted during emergency. Placental localization must be done in all women with previous cesarean delivery by ultrasonography or MRI to detect placenta accreta or percreta, and all women with prior cesarean delivery must have their placental site determined by ultrasound or MRI to determine the morbid adherent placenta. And the women with morbid adherent placenta are at high risk of PPS. Such a case should be delivered by a senior obstetrician, and availability of the blood and blood products must be ensured beforehand, and multidisciplinary team approach should be made in such cases. In the internatal prevention, the active management of the third stage of labor for all women in the labor should be a routine as it reduces the PPS by 60%. And you can check our video on active management of third stage in our channel, and we have already discussed about that. And cases with induced or augmented labor by oxytocin, the infusion should be continued for at least 1 hour after the delivery. And the woman delivered by cesarean section, the oxytocin 5 international unit slow IV is to be given to reduce the blood loss. And carbetocin, long-acting oxytocin 100 microgram IV is to be given over 1 minute is very useful to prevent postpartum hemorrhage. And the exploration of the uterovaginal canal for evidence of trauma following difficult labor or instrumental delivery can be done. The observation for about 2 hours after delivery to make sure that the uterus is hard and well contracted before sending out to ward. Expert obstetric anesthesia is needed when the delivery is conducted under general anesthesia, and local or epidural anesthesia is preferable to general anesthesia in forceps, ventouse, or bridge delivery. And during cesarean section, spontaneous separation and delivery of placenta reduces blood loss to around 30%, and examination of placenta and membrane should be a routine to detect at the earliest any missing part. And as all said and done, it is the intelligent anticipation, skilled supervision, and prompt detection and effective institution of therapy that can prevent a normal case from undergoing the disastrous consequences. And now we will talk about most important part, that is management of third stage bleeding. And as we have already said, third stage of bleeding includes third stage bleeding or third stage hemorrhage include the bleeding before the expulsion of placenta. And the true postpartum hemorrhage includes the bleeding that occurs after the expulsion of placenta. Now we are going to talk about bleeding that occurs before expulsion of placenta, also known as third stage bleeding. And this is not the true PPH. The principle of management of the third stage hemorrhage are the to empty uterus of its content, removal of placenta, and to make it contract, and to replace blood on occasion patient may be in the shock. In that case, the patient is managed for shock first, and to ensure effective hemostasis in traumatic bleeding. And the steps of management are the one is placental site bleeding, and for placental site bleeding we have to palpate the fundus and massage uterus to make it hard. The massage is done by placing forefinger behind uterus and thumb in front. And however, if bleeding continues even after the uterus becomes hard, it suggests the presence of genital tract injury. To start crystalloid solution, normal saline or ringer lactate solution with oxytocin 1 liter with 20 unit or 60 drops per minute, and to arrange for blood transfusion if necessary. And oxytocin 10 unit intramuscular or methadone 0.2 mg is given intravenously. Carbetocin or longer acting oxytocin derivative is found 100 microgram as effective as oxytocin infusion. Next is we have to catheterize the bladder and to give the antibiotic, the ampicillin 2 gram and the metronidazole 500 milligram intravenous. And after all this procedure, if the feature of placental separation are evident, and if there is evidence of placental separation, the expression of placenta is to be done either by fundal pressure or by controlled cord traction method. And if the placenta is not separated, the manual removal of placenta under general anesthesia is to be done. And in case the patient is in shock, she is resuscitated first before undertaking the manual removal. And if the patient is delivered under general anesthesia, quick manual removal of the placenta solves the problem. And in cases where oxytocin 10 unit is given IM with the delivery of the anterior soldier, manual removal is done promptly when the 2 attempt of the controlled cord traction fails. And the placenta is normally separated, and the delivery delivered within 5 minutes of delivery of the baby, and in 50% of the cases, and within 15 minutes in 90% of the cases. For management of the traumatic bleeding, the uterovaginal canal is to be explored under general anesthesia after the placenta is expelled and the hemostatic suture are placed on the offending site. Now we will talk about management of true postpartum hemorrhage, that is bleeding subsequent to the expulsion of placenta, bleeding after the separation of the placenta, and bleeding after the expulsion of placenta. And the principle of management of the true postpartum hemorrhage are principle followed is the simultaneous approach, that is communication, resuscitation, monitoring and arrest of the bleeding. These are all done simultaneously, and it is essential in all cases of major postpartum hemorrhage, that is blood loss more than 1000 ml or clinical shock. This principle should be done. It is essential. And the golden 1 hour is the time at which the resuscitation must be started to ensure best chance of survival. And the probability of survival decreases sharply after the first hour if the patient is not effectively resuscitated. And the shock index is used as the valuable guide in the monitoring and general management of the women with the postpartum hemorrhage. And dividing the heart rate by systolic blood pressure, as we have talked, communication, resuscitation, monitoring, arrest of bleeding. And the golden hour 1 hour is the time at which the resuscitation must be started to ensure best chance of survival. The probability of survival decreases sharply after the first hour of if patient is not effectively resuscitated. And we talked about shock index. It is used as a valuable guide in the monitoring and general management of a woman with PPH, and it is calculated by dividing heart rate with systolic blood pressure, and the normal value is 0.5 to 0.7, and however with major hemorrhage it increases to 0.9 to 1.1. And change in systolic in the shock index is a better indicator to suggest early acute blood loss than the heart rate, SVP or diastolic BP when used alone. Now, what are the immediate management of the true PPS? The immediate management measures are to be taken by the attending house officer or the midwife, and the call for extra help that involves the obstetric registrar, senior staff on call duty. The obstetrician is called for help, senior officer, and we have to firstly commence IV line with 2 wide bore cannulas, 14 gauge intravenous cannula. The patient is kept flat and warm. Then blood has to be sent for full blood count, blood grouping, cross matching, diagnostic tests such as renal functional test, liver function test, coagulation screen including the fibrinogen, and asking for 2 unit at least of the 2 unit of the blood should be asked, and infuse rapidly 2 liter of normal saline, that is crystalloid or normal saline crystalloid or plasma substitute like Hemacil, that is colloid, and urea linked gelatin to re-expand the vascular bed, and it does not interfere with the cross matching. And give oxygen max by 10 to 15 liter per minute, and start 20 to 40 unit of oxytocin in 1 liter of normal saline IV at the rate of 20 to 40 drops per minute and transfuse blood as soon as possible. And one midwife or rotating houseman should be assigned to monitor the following, like blood pulse, blood pressure, temperature, respiratory rate, oximeter, type and amount of fluid, that is blood product patient has received, urine output, the continuous catheterization, drug type, dose, time, and central venous pressure when it is cited, and that should be all done. There is something known as rule of 10 for management of PPS. As we have already said, the for monitoring we have to do various monitoring, and the while monitoring the patient, if the fall of systolic blood pressure is less than by 30 millimeter mercury, if the rise in heart rate by 30 beats per minute, rise in respiratory rate by 30 breaths per minute, drop in hemoglobin or hematocrit by 30%, fall in urine output by 30 ml per hour. With this observation, the patient has lost at least 30% of the blood volume and she is in the moderate shock leading to severe shock. Talking about actual management, after the immediate management, we have to do the actual management. And the first step is to control the fundus and to note the feel of the uterus. If the uterus is flabby and the bleeding is likely to be from the atonic uterus. If the uterus is firm and contracted, the bleeding is likely to be traumatic. That is the way to differentiate between atonic uterus and the traumatic PPS. So by feeling the uterus, if the uterus is flabby, then that is atonic uterus, and this is most important one to control the bleeding in the atonic uterus. So in the management of the atonic PPS in atonic uterus, the first step 1 is to massage the uterus to make it hard and express the blood. First is to massage the uterus to make it hard and express the blood clot. Methergine 0.2 mg is given intravenously. Injection of oxytocin drip is started. 10 unit in 500 ml of normal saline at the rate of 40 to 60 drops per minute. The Foley's catheter is to keep the bladder empty and to monitor the urine output. To examine the expelled placenta and the membrane. Step 2 for examination of placenta and membrane for evidence of missing cotyledon or piece of membrane. And if the uterus fails to if the uterus fails to contract even after this step, then we have to proceed to next step 2, if this management fails. And the next step is the uterus is to be explored under the general anesthesia. The simultaneous inspection of the cervix, vagina, especially the paraurethral region, is to be done to exclude coexisting bleeding site from the injured areas. In refractory cases, injection methyl prostaglandin F2 alpha 250 microgram IM in the deltoid muscle every 15 minutes up to maximum of 2 mg can be given, or misoprostol prostaglandin PG 1000 microgram per rectum is effective. Injection tranexamic acid 0.5 gram or 1 gram IV may be given to addition for oxytocin, or when the uterine atony is due to tocolytic drug, calcium gluconates 1 gram IV slowly should be given to neutralize the calcium blocking effect of this drug. The third step is uterine massage and bimanual compression. In this process, the whole hand is introduced into the vagina in the cone-shaped fashion. After separating the labia with the finger of the other hand, the vaginal hand is clenched into fist with the back of the hand directed posteriorly and the knuckles in the anterior fornix, and the other hand is placed over the abdomen behind the uterus to make it anteverted. The uterus is firmly squeezed between two hands, and it may be necessary to continue the compression for a prolonged period until the tone of the uterus is regained, and this is evidenced by the absence of bleeding if the compression is released. And during this process of uterine massage, during this period, the resuscitative measures are to be continued, and if in spite of therapy the uterus remains refractory and the bleeding continues, the possibility of the blood coagulation disorder should be kept in mind, and the massive flesh whole blood transfusion should be given until the specific measure can be employed. However, with the oxytocin, the blood transfusion almost all cases respond very well. The uterine contraction and retraction regain, and the bleeding stops. But in rare cases, when the uterus fails to contract, the following may be tried desperately as an alternative to hysterectomy. Next is step 4. Uterine tamponade. The tight intrauterine packing is done uniformly under general anesthesia. A 5-meter long strip of gauze 8 centimeter wide folded twice is required, and the gauze should be soaked in the antiseptic cream before introduction. The gauze is placed high up and packed into the fundal area first, while the uterus is steadied by the external hand. Gradually, the rest of the cavity is packed uniformly so that no empty space is left behind, and the separate pack is used to fill the vagina. And an umbilical binder is placed. Intrauterine plugging acts not only by stimulating the uterine contraction but exerts the direct hemostatic pressure tamponade effect to the open uterine sinuses, and antibiotics should be given and the plug should be removed after 24 hours. And intrauterine packing is useful in cases of uncontrolled postpartum hemorrhage where the other method have failed and the patient is being prepared for transfer to a tertiary care center. Next we have the balloon tamponade. Tamponade using various type of hydrostatic balloon catheter has mostly replaced the uterine packing. The mechanism of action is similar to uterine packing, that is the Foley catheter, Buckley balloon catheter, condom catheter, or Sengstack Baltimore tube is inserted into the uterine cavity, and the balloon is inflated with the normal saline 200 to 500 ml, and it is kept for 4 to 6 hours, and it is successful in orthotic PPS. This can avoid hysterectomy in 78% cases, and it is considered the first line surgical intervention for most women with orthotic PPS. Uterine tamponade Buckley balloon. And other measures with non-pneumatic anti-shock garment may be used when the patient is being transferred to referral center. Compression of the abdominal aorta may be temporary but effective measure, and this allows time for resuscitation and the volume replacement before any surgical intervention is done. Then we have the uterine artery embolization (UAE). The bleeding vessel under fluoroscopy interventional radiology can be done using jello foam. Success rate is more than 90% and avoids hysterectomy. Internal iliac arterial balloon and catheter are also be used. And gelatinous sponge gel foam particles are injected into the bleeding vessel, uterine artery or internal iliac vessel. The its advantages are bleeding is controlled, uterus is preserved, and the future fertility is restored, and the complication rate is very less. And step 6. The surgical method to control PPS are many. An outline of stepwise uterine devascularization procedure are given below. The B-Lens compression suture 1997 and the multiple discard suture. Both these surgical methods work by tamponade like manual compression of the uterus, and the success rate is 80% and it can avoid hysterectomy. Number 1 catgut suture is used. This is B-Lens breast suture for control of orthotic PPS. Both of these surgical methods work by tamponade of the uterus. Then the next method of devascularization can be ligation of uterine artery. The descending branch of uterine artery is ligated at the lateral border between upper and lower uterine segment, and the suture number 1 chromic catgut is passed into the myometrium 2 cm medial to the artery, and the orthotic hemorrhage. The bilateral ligation is effective in 75 to 90% of the cases. Then we have the ligation of ovarian and uterine artery anastomosis. If the bleeding continues, it is done just below the ovarian ligament, and the rarely temporary occlusion of the ovarian vessel at the infundibulopelvic pelvic ligament may be done by rubber sleeve clamp. And the ligation of anterior division of internal iliac artery, unilateral or bilateral, reduces the distal blood loss flow, and it helps stable clot formation by reducing the pulse pressure up to 85%. And due to extensive collateral circulation, there is no pelvic tissue necrosis, and bilateral ligation can avoid hysterectomy in about 50% of the cases. This is picture of ligation of internal iliac artery. The right sided, it is done below the origin of the posterior division. This is common iliac, this is internal iliac, this is posterior division, this is in anterior division, and it is done it is done below the origin of posterior division of in the anterior division. The dissection of the hypogastric artery. This is the dissection of the hypogastric artery, right, and passage of silk thread with a right angle forceps. The artery, internal iliac artery, is gently lifted up with Babcock's forceps. The artery is tied with number 1 silk at 2 places, and the artery is not transected in between ties, and the pulsation of branches of external iliac artery must be checked before and after procedure. Finally, the seventh step we have is the hysterectomy. Rarely uterus fails to contract and the bleeding continues in spite of above measure. Hysterectomy has to be considered even involving the second consultant, and decision of hysterectomy should be taken earlier in parous women. It is a life-saving measure, and depending on case, it may be subtotal or total. And tranexamic acid is an antifibrinolytic agent. It prevents activation of plasmin agent to plasmin, and it reduces blood loss significantly, according to WHO. Next, we have the traumatic PPS. The trauma to the perineum, vagina, and the cervix is to be inspected under good. This is management of traumatic. Up to now, we have discussed about ortonic. Now, we are going to discuss about traumatic PPS management, and this is very short. And the trauma to the perineum, vagina, and cervix is to be inspected on a good light by speculum examination, and the hemostasis is assessed by appropriate catgut suture, and repair is done under general anesthesia if necessary. And skill drill for management of PPS management for all birth attendant is essential to improve outcome, and documentation of all measures adapted in the respective time should be done. So that was all about the management of postpartum hemorrhage. And in next video we will be coming with the next topic in obstetrics. Okay, before leaving, let's discuss about secondary postpartum hemorrhage also. Okay, so what is secondary postpartum hemorrhage? It is the hemorrhage that occurs after 24 hours and within the puerperium, and it is also called as delayed or puerperal hemorrhage. And the late bleeding usually occurs between the 8th to 14th day of delivery, and the causes of late postpartum hemorrhage are: one is subinvolution of the placental bed, the second one is retained bit of cotyledon or membranes. Next, we have the infection and separation of the slough over the deep cervicovaginal laceration. Fourth one is endometritis and subinvolution of the placental side due to delayed healing process. The secondary hemorrhage from the cesarean section won't usually occur between 10 to 14 days, and this secondary hemorrhage from cesarean section wound is commonly due to separation of slough, exposing a bleeding vessel from granulation tissue, withdrawal bleeding following estrogen therapy or for suppression of lactation, and other rare causes are chorion epithelioma that occurs usually beyond 4 weeks of the delivery, and carcinoma cervix, placenta polyp, infected fibroid, and the uterine arteriovenous fistula formation, and the puerperal inversion of the uterus. And we have the diagnosis. The bleeding is bright red and of varying amount. Rarely it may be brisk. Varying degree of anemia and evidence of sepsis are present, and internal examination reveals evidence of sepsis, subinvolution of the uterus, and often patulous cervical loss. And the USC is useful in the detecting the bits of placenta inside the uterine cavity. The principle of management is to assess the amount of blood loss and to replace it with the blood transfusion, to find out the cause and to take appropriate steps to rectify it. The supportive therapy is our blood transfusion if necessary, to administer methadone 0.2 mg intramuscularly if the bleeding is uterine in origin, to administer antibiotic like clindamycin and metronidazole as a routine, and conservative if the bleeding is slight and no apparent cause is detected, or careful watch for a period of 24 hours or so is done in hospital. And the active treatment includes as the most common cause is due to a retained bit of cotyledon or membrane, it is preferable to explore the uterus urgently under general anesthesia. And one should not ignore the small amount of bleeding, as unexpected alarming hemorrhage may follow sooner or later. The products are removed by ovum forceps, and the gentle curettage is done by using flossing curette. And the methadone 0.2 mg is given intramuscularly, and materials removed are to be sent for histological examination. The presence of bleeding from sloughing wound of the cervicovaginal canal should be controlled by hemostatic suture. The secondary hemorrhage following caesarean section may at times require laparotomy, and the bleeding from uterine wound can be controlled by hemostatic sutures, may require rarely uterine artery embolization, ligation of the internal iliac artery, or may end in hysterectomy. So thank you. That was all about postpartum hemorrhage, and in next video we will come up with new topic on obstetrics. Thank you and have a nice day.